So again, welcome to Wonderful Wednesday, and this is acute heart failure in the critical care setting. So lots of things to know about acute heart failure, and particularly as we're evolving in the understanding and the management of heart failure. What my number one focus is to talk about acute heart failure, not chronic heart failure, and not necessarily decompensated heart failure, which typically is cardiogenic shock, but to just talk overall about heart failure and how it affects us every day in the emergency department, in the MICU, and the CVICU, and in the trauma surgical unit as well, just about everywhere patients go inside of our hospital. So one of the things that we know now, and these are from 2018 statistics, that in-hospital mortality for decompensated heart failure is 6.4%. That's pretty significant when we talk about management of patients in hospital in an intensive care unit. For persons who are between the age of 65 and 69, prevalence of heart failure is 20 per 1,000. But after age 65, 80 in 1,000 starts to be the incline. When you reach 85 years of age, about 80 in 1,000 persons who present to emergency rooms will be presenting to the emergency room with symptoms of breathlessness on exertion. And in the majority of those patients who have breathlessness on exertion, 1 in 6 of those will have unrecognized heart failure. So I'm going to use a little term here, HFpEF. That P, we're going to talk about that in a moment. That P stands for preserved ejection fraction. What that basically means when we say preserved ejection fraction is that this is one of the major issues that we see with patients who have heart failure, in that they maintain their contractile function, but they're not able to fill with volume. And that's the kind of patient, the patient with a preserved ejection fraction, that we often see spottily throughout the hospital, who may not actually have a primary cardiac diagnosis, might not have a cardiologist on board, but is receiving aggressive positive pressure ventilation with a lot of positive pressure that then puts a very significant load on the right heart. And they may preserve their ejection fraction. Their problem is actually filling of the right heart. And since they're not filling the right heart, filling of the left heart. That's the most common form of heart failure that we see in a non-cardiac population. But in the cardiac population, the most common form of heart failure that we see will be reduced ejection fraction, or what we call systolic heart failure. Now, some of the things that actually exacerbate heart failure, and there's a lot of them, there's a couple of things that we as bedside nurses should always be aware of when we see patients who present with signs and symptoms of heart failure, or who have a diagnosis of heart failure, either primary or secondary to some other event. The single most important issue that I think is overlooked a lot is the prospect of hyperthyroidism. And really, really important to remember, and actually thyroid dysfunction, I should say, not necessarily hyperthyroidism. Hyperthyroidism typically lends itself to the presentation of the failure to fill type of heart failure that's called diastolic. You have a preserved ejection fraction, but you're not able to fill the ventricles effectively. That occurs with uncontrolled hyperthyroidism. Typically, hyperthyroid patients get diagnosed pretty quickly. They are very tachycardic. They tend to be hypertensive. They have diastolic dysfunction of the heart. They have a low cardiac output. They're hyperthermic. Everything is high. Everything is high. And they get diagnosed pretty quickly. The ones who don't get diagnosed that quickly, and oftentimes are very much overlooked, and especially in women over the age of 55, are those patients who present with hypothyroidism. Hypothyroid patients often will have reduced systolic function or reduced ejection fraction, and they can be really quite ill under our care. And we may not be looking at the role of the thyroid hormone in the integral management of cardiac function. This is very, very significant. So that's the first thing I really want to focus on. I also want to focus on any type of functional anemia. Now, functional anemia, we've had a lot of differentiation in that diagnosis over time. 15, 18, 20 years ago, if your hemoglobin was less than 12, we typically gave you packed cells. We wanted to get your hemoglobin up. We don't really do that anymore. In fact, we don't like to use a hemoglobin number as making a decision about whether or not you need packed cells. Mostly we make decisions about resuscitating patients with blood or with packed cells based on whether or not they have metabolic acidosis. So one of the things that we know with patients who have functional anemia and a low oxygen carrying capacity, that's what a low hemoglobin creates, a low oxygen carrying capacity, that puts an extraordinary burden on the myocardium to actually increase stroke volume and cardiac output to make up for the absence of functional oxygen carrying components. So that's something else I really want you to pay attention to in your patient population. You're thinking that you're caring for a GI bleeder, but you may also be putting an extraordinary burden on the myocardium. Or you're caring for somebody who has renal dysfunction, so they already have volume overload. And in addition to that, they are anemic. And that puts an extraordinary burden on myocardial function. So we want to think outside of the cardiac box when we're thinking about heart failure. And remembering, of course, that the primary cause of heart failure is some cardiac anomaly, a structural deficit, a valvular abnormality, an electrical abnormality that actually affects the ability of the chambers of the heart to maintain a consistent and correlated, synchronized approach of filling, contraction, filling, contraction. And that's really important when we look at a patient. We're in a room with a patient who has dropped their blood pressure, who has some dysrhythmia, and probably most commonly that dysrhythmia will be atrial fibrillation. We're trying to figure out what the heck's going on, but we're not reminding ourselves that new onset atrial fibrillation will be a form of heart failure because you've lost the atrial contractibility to actually load the ventricle with volume. So the reason I chose heart failure, even though Wednesdays are usually cardiac day anyway, is because I think that when we hear the word heart failure, it's like hearing the word STEMI. It's like that only is happening for cardiac patients, but really isn't underlying some of the bigger problems that I might be having with my patient, with maintaining perfusion, with clearing metabolic acidosis and lactic acidosis. But we always have to go back and look at the heart and remind ourselves that you can have a chronic or an acute on chronic heart failure, but you also can have what I would call an iatrogenic heart failure, a heart failure that's been caused by some of the interventions that we're applying, by your instability, by your volume loading, by your renal function, by your pituitary function, and by your thyroid function. Oh my God, it's a lot to remember and a lot to think about, but it's a really important perspective. So if we just remind ourselves about generalized heart failure, we're going to remember that much heart failure develops over time. So when we think about patients who have comorbid diseases like hypertension, which is over time, or diabetes, particularly not well-controlled diabetes. And for most patients who have type 2 diabetes, they are they're very cavalier about their management because they don't go into DKA. And in general, they are not in events that put them at risk for HHS, but they just have a higher level of glucose. The cells are starving. All that excess glucose is getting delivered into the myocardium and promoting a very high myocardial metabolism. But they're not thinking about, okay, I've had 12 years of diabetes. I spent 6 months like pricking my finger, really managing my blood sugar, managing my diet, doing exercise. It was just too much. And, I'm on these medications to get my glucose under control and things must be all right because my doctor is saying that over time, my hemoglobin A1C doesn't look that terrible. Maybe it's 6.8 or it's 7.2, but it was 10 or it was 9. So I'm doing pretty good. However, that uncontrolled diabetes. So for me, I don't care what your diagnosis is for diabetes. I want you sticking your finger 8 times a day. I want to know what your blood glucose is. I want you to adjust for that to really control it. I'm very, I have a lot of expectations for patients and what I want patients to do. You can imagine being in my family and being sick. You're in trouble now. We just want to remind ourselves that this slow kind of comorbid encroachment upon cardiac function does, of course, put your myocardium at risk. And again, I want to make sure we appreciate that when we're thinking about diabetes, that glucose in the serum is hypoglycemia in the cell. And that means that any cells that require insulin for delivery of glucose are going to be hypoglycemic. They're going to communicate hormonally to create more glucose. The glucose in the serum goes up, but the cerebral cells and the myocardial cells uptake glucose without the benefit of insulin. So every sustained episode of hyperglycemia puts your myocardium at risk and is a co-contributor for heart failure. So I might not have had diagnosed heart disease. I might not have an acute coronary syndrome. I didn't come to the hospital for a STEMI, but I'm a diabetic who's been known that I've had diabetes for 20 years and been somewhat in control. My hemoglobin A1C is less than 7 or 7.5, but I actually have myocardial disease associated with that episodic failure to control my glucose. Same thing with hypertension. And particularly, so when we think about our population of patients, we have many patients with uncontrolled diabetes because they live in food deserts, they don't have access to healthcare, they are not able to find physicians who understand them culturally or who look like them, and they feel uncomfortable coming to the hospital, and the only time they come to the hospital is when they're really sick, and they're really out of sorts with their hyperglycemia and their blood pressure. So, of course, we all know that triad of diabetes, hypertension, heart disease. It is really important to remember that the day you diagnose them is not the day this began, because uncontrolled hypertension, which then promotes a very significant series of events that actually increase the work of the heart exponentially. And as we increase the work of the heart, we increase the metabolism of the heart, we increase the oxygen consumption of the heart, and that puts the patient at risk for heart failure. Now, it's pretty straightforward to appreciate that somebody who's having an acute ischemic event, especially an acute STEMI, can go directly without passing any go, maybe didn't have comorbidity or comorbidity was well managed. Maybe they don't have hypertension, they don't have diabetes, or they do, but it's been well managed. But now they have a STEMI. And that STEMI, remember that as you are putting myocardium at risk with an absence of appropriate blood flow and oxygen supply, that you actually cause disruption of the myocardial function, and that is quite expansive. That's why one of the reasons that with the AHA, get with the guidelines, STEMI Gold, which is what we are here at Grady, is the number one important concept is how quickly do you open an artery? You got to open an artery within 60 to 90 minutes. Our goal is less than 90, but we'd like to achieve less than 60. So that means that if a patient is presenting with a STEMI, we really have a very short period of time to try to resuscitate and protect the myocardium. When a patient is at home having some chest discomfort, doesn't want to call the ambulance, can't really afford it, doesn't have insurance, don't know what they're going to do, call their friend says, I'll come and get you, but I've got to get off work. It's going to be 40 minutes. I'll be there in 45 minutes, and then I'll take you to the hospital. And it's an hour later, and they've had chest pain for a couple of hours, and they have an extensive STEMI. That perspective then puts them, of course, at profound, significant risk for cardiac failure. So those things are not a big surprise. Any injury to the myocardium, either acute injury or overtime injury. And again, remembering overtime injury is really related, most particularly to the control of diabetes and the control of hypertension. And then we think about what ends up happening. No matter why this is happening, whether it's short-term, whether it's an acute event or whether it's a long-term event and a chronic event, what is actually going to happen is that there are changes in the ventricular wall. And that change in the ventricular wall is really related to metabolism, which is why I cannot emphasize enough how important it is to control glucose and to really teach patients about how to control their glucose, because that is one of the major factors in causing this metabolic structural abnormality of the ventricular wall. Then the electrophysiologic issues, which are impaired conduction, that can occur when you have electrolyte imbalance or you have myocardial ischemia, where the conduction puts the cells are put at risk for formulating abnormal electrical depolarization. So you see patients that are having a fib or a flutter, they're having PACs, PJCs, PVCs, VTAC, VF, all of which is indicating to us a failure of the balance of the ions and the oxygen in the myocardial cells. And then last but not least is that once the myocytes, the individual myocardial cells, have been altered, they actually change their functionality, and that ventricle actually becomes remodeled. And typically the ventricle becomes remodeled with hypertrophic tissue that is less functional, or a dilation of the ventricular chamber. That's what we're talking about with ventricular remodeling. Ventricular remodeling is what occurs that puts your patient further and further and further at risk in heart failure. So I've made this little drawing. I saw something like it somewhere and I thought, this is really great. This little drawing to remind us that despite whatever's happened to you already, if you are presenting to us with heart failure, we're going to remind ourselves that ultimately it's about the failure to stay in balance with the delivery of oxygen via blood to maintain tissue function, to deliver metabolic substrate like glucose to the cells, to deliver appropriate oxygen to the cells, and also that you may not be able to fill with your venous volume, so your veins become engorged. That volume road may become static, so you're very engorged in your veins. You have interstitial volume loading, or what we call fluid creep, from the veins out into the interstitium. And now we have a whole constellation of symptoms that we have to think about. Now, when we talk about the heart, our focus is always, as my focus is always, about stroke volume. Stroke volume is the amount of volume ejected by the heart per beat. Stroke volume times heart rate is cardiac output. Now, normal cardiac output is 4 to 8 liters a minute, but your cardiac output should be variable depending on what your tissue demands are. Your tissues demand more oxygen, you should be able to upload your cardiac output. If your tissues are demanding less oxygen, you should be able to download your cardiac output. And that is all a balance of how the heart responds to sympathetic stimulation, renin-angiotensin, other metabolites, and it requires that you have a really good structure. So when we think about patients who have heart failure, who already have an altered structural design of the myocardium and the myocardial response, we're just going to remind ourselves that what we're going to affect on these patients, what we're going to treat, is what we talk about as preload, afterload, and myocardial contractility. So I love this whole idea here. On this stagecoach, whatever it is that they're carrying, this coal or luggage or clothing, whatever it is they're carrying is preload. The more you carry, the harder your work is. The harder it's going to be to pull it, the harder it's going to be to move it. So for us, when we talk about preload, we primarily talk about the volume that fills the ventricle and the compliance of the ventricle wall. But for our purpose today, we're just going to talk about it as volume. That's your preload. The afterload is the amount of tension that has to be developed to move the volume. So I filled my ventricle, that's the preload, and now I've got to move that volume up this steep incline. So as the stagecoach is showing you, you've got this huge burden that you got to move up a steep incline. That's called your afterload. Afterload is a measurement of resistance or tension that must be developed by your heart in order to move the preload. To move preload against afterload, you must have contractility. And in this visual, the contractility are these men and a woman who are getting behind the stagecoach, pushing the coach up. They are adding force, and that force is what we call contractility. So in the simplest of terms, we're going to say volume load, tension that you must eject against, called resistance, and the force of the heart, preload, afterload, contractility, or inotrope. And all of those things combine together to create the cardiac work. So you can see these folks behind are pushing. This guy up here is driving the horses. You've got this big, big load, this big burden that you've got to move up the steep hill, but all the work is being done by the horses. And that, I would say, you've got 3 ventricles here, so that's unfortunate. I wish there were only 2 horses. I could say the right and left ventricle, but by the horses. They're the ones who are doing the work against the resistance moving the volume, and they've got a little bit of force support by the people behind the stagecoach. Now, when we think about heart failure, it's always really important. Our first focus typically is going to be the left ventricle, although that's not the only problem that occurs. But if you have a failing left ventricle, so you've got very significant ischemia, you've got a failing left ventricle, now you have stasis of volume in the pulmonary veins, that by the fact of hydrostatic pressure, a lot of volume in my veins, that volume moves out from the vein into the interstitium, and that causes, of course, pulmonary edema. Now, as we get volume in the pulmonary vault, we compress the alveoli. That decreases the lung compliance. It makes it harder for me to breathe, harder for me to oxygenate. I'm going to have to work harder to breathe. I'm not on any support. I'm at home. I'm working harder. My diaphragm is working harder to generate negative inspiratory pressure or force to get gas into my lung. Okay. Now that also changes my thoracic pressure. Okay, now when that changes my thoracic pressure, I'm breathing spontaneously, my diaphragm descends, that's going to suck volume into the right heart. So that's just with spontaneous breathing, negative pressure breathing sucks volume into the right heart. And that means more volume is going to get returned to the left heart. The left heart has to work harder. It increases its oxygen supply, gets more ischemic, more pulmonary edema, decreased lung compliance, have to work harder to breathe, not breathing very well, increased preload, and on and on and on and on. And other things that, of course, can happen, in that situation are that when we talk about the pressure in the thoracic vault, that also is going to affect the compliance of the ventricle and the way volume returns to the ventricle. So of course, one of the first things we would do if we were seeing a patient who was struggling, who was short of breath, who had fluid creep in the pulmonary vasculature and in the pulmonary interstitium, the very first thing we're going to want to do is we want to shift them from negative pressure to positive pressure breathing. So the very first thing you're going to do, no matter where it is you're working, if you were looking at somebody who has assumed or defined heart failure, who is working hard to breathe, the very first thing you're going to do is positive pressure breathing. And you'll start with CPAP. All CPAP does really is it changes the amount of work that patient is doing to move gas into the lung. And by changing that negative pressure to positive pressure, it really impacts the way the heart is filling and ejecting and how hard the heart is having to work, because we've reduced that negative pressure volume load of the ventricle, and we've reduced the oxygen consumption of the diaphragm. Now, when your patient presents with some form of heart failure, left failure, right failure, biventricular failure, really, really important to appreciate three primary mechanisms by which your patient is going to try to compensate. So the first mechanism is that the stretch of the ventricle is going to be increased because the patient is going to give himself a volume bolus. As you stretch the ventricle, the recoil should be better. That's called the Frank-Starling mechanism. The other thing that's going to happen is that the cells themselves are going to become more stretched, bigger and longer, and that's called cardiomyocyte hypertrophy. And the third one, which is the one that you work on all the time, you're not really working on Frank-Starling, you're not really working on cardiomyocyte hypertrophy, you're working on this one, the neurohormonal activation, which is a major compensatory mechanism. Whenever your heart does not meet the demand for the tissues, you're going to have an increased sympathetic stimulation. So that means your sympathetic nerve traffic down your spinal cord increases. And that sympathetic stimulation is going to result in an increase in your heart rate, an increase in your vasoconstriction, an increase in your contractility, an increase in your venoconstriction, meaning more volume back to the heart. So an increased heart rate, an increased contraction, a constricted arterial bed, and a constricted venous bed. That's the first thing that happens with sympathetic activation. So I've made the heart work harder and faster against more resistance. So afterload is up, and with more volume. So preload is up. So preload now is up and afterload is up, and I have a heart that's already at risk, and I'm giving it 2 extra burdens. So one of the first things that we do when we're talking about these patients is we talk about how to block sympathetic activity. And the primary sympathetic activity that we block is the sympathetic activity at the heart. And that's why we use beta blockers. Beta blockers blocks this normal compensatory response that is putting your patient at risk. The other thing that happens with these patients, and there are many things, and the ones we're talking about, the ones that we do something about, okay, is the renin, angiotensin, aldosterone axis. So as soon as there's sympathetic activity, as blood volume to the kidney goes down, the kidney at the entry point to the kidney, you're going to release a hormone known as renin. That renin is going to convert ultimately to angiotensin 2, which is a profound vasoconstrictor. And that angiotensin 2 also stimulates the release of aldosterone, which promotes salt and water reabsorption and wastes potassium. So my potassium starts to go down, which is going to affect my cardiac contractility and my electrical activity of my heart. Potassium starts to go down because I'm wasting potassium, retaining salt and water. And my preload has gone up. And my angiotensin is a very significant vasoconstrictor. So yet again, maybe I didn't have any myocardial dysfunction to begin with, but my preload now is up and my afterload is up, and the work of the myocardium is significantly increased. So that's why we use ACE inhibition, or we use angiotensin receptor blockers. So we use beta blocker, ACE inhibitor, angiotensin receptor blocker, and we try to promote that our patient will diurese. So we're blocking that whole anti-diuretic system. There is something else that in other countries, not here in the United States, although some places in the United States, but not here at Grady, we also look at blocking or by not blocking, but administering patients a very specific natriuretic hormone that's called natriuretic nucleotide. We don't use it here, natriuretic, because there are some pretty significant side effects in association with utilizing it. Other hospitals do use it. We don't use it here. It is approved by the FDA. And those are really the four major things that we affect. We block beta, we block your sympathetic system. We block conversion or reception of angiotensin and aldosterone. We promote diuresis, usually with a loop diuretic. And in some hospital systems, again, not here at Grady, we will actually administer beta natriuretic hormone to help you waste salt and water. So that's a really important perspective that we want to understand. So again, if we look at compensatory mechanisms, 1 + 2 + 3, here's what happens to your patient initially in heart failure. The contractile mechanism increases until they give out. Their heart rate goes up. They constrict the artery in the vein. They reabsorb water and salt. They increase initially their effective circulating volume. They increase the mass of the ventricle, meaning that they hypertrophy their ventricles, and they increase the volume in the ventricle at the end of filling. Now, the volume in the ventricle at the end of filling and the ventricular mass will end up with significant deficits of the heart, right? You'll be dilated and you will be hypertrophied because you've remodeled. But the other thing that's really important is to appreciate that you cannot sustain increased contractility and increased heart rate for a long period of time because the myocardium is asking now for lots and lots of oxygen, and it puts the myocardium at risk. I really wanted to focus just a tad bit because it's such an important tool that we use and we need to always pay a lot of attention to it. And that is that when you are stretching, particularly the atria, and most particularly the left atria, but also the right atria, when those walls become stretched because I've got too much volume in the atria, we're going to release atrial natriuretic peptide hormone from the left and right atria, leftmost, right atria second most. And we also are going to release beta natriuretic hormone. Now that B type is actually, we call it brain, but it's in the brainy muscle, the ventricle. And the ventricle is going to release this beta type natriuretic hormone. So we've stretched our ventricle. We've released beta natriuretic hormone. We've stretched the atria. We release atrial natriuretic hormone. But what we look at is evidence that you have released beta natriuretic hormone in your blood. Now, The impact of the beta natriuretic hormone will be to vasodilate you. Well, that's beautiful. You have vasodilation. So if you were having a high level of blood pressure because you had arterial resistance, you're not going to reduce some of that resistance and your blood pressure is going to come down. That's a very happy thing. But you actually have to be able to respond to the beta natriuretic hormone. Most patients in heart failure don't respond to that. They just have circulation, but not response. And these two hormones actually, when delivered to the kidney, increasing the volume to the kidney, that means that the renin at the renal bed will reduce. If the renin reduces and angiotensin and aldosterone are going to reduce, that will reduce your patient's overall blood volume. And because you'll have better blood volume going to the kidney, you'll be able to waste salt and water. All that's very lovely and hypothetical. The problem is that in a heart failure patient, the release of beta natriuretic peptide hormone, if it's not utilized, the level of that hormone in the blood goes up, but the function of the hormone actually goes down. So it's just like glucose. When you see glucose in the serum, it means you don't have glucose in the cell. When you see a high level of beta natriuretic hormone in the blood, it isn't actually doing what it's supposed to, because it would be degraded if it had that effect. So we all know that we like to look at beta natriuretic hormone. Any hormone level of BNP that you measure when you're evaluating heart failure, if it's less than 100, that is strongly against the diagnosis of acute heart failure. Anything between 100 and 400 is going to be suggestive of heart failure. Anything greater than 400 is actually diagnostic for heart failure. There are other reasons that beta natriuretic peptide hormone goes up, but when we're looking at a person who is huffing and puffing, and it might be hypoperfused, has evidence of venostasis, neck veins are distended, lungs are wet, we're going to say any increase in beta natriuretic hormone is telling us that we have a patient who has heart failure. Patients who are obese, sometimes older women, renal disease patients, AFib patients, patients with pulmonary hypertension, not STEMI patients, but patients who have these other kinds of alterations, which actually may not be pure heart failure, but typically is some kind of cardiac volume overload, will have an elevated BNP. We're going to use BNP, and we're going to remember BNP levels that are up in the blood mean less action of BNP at the endpoint, at the vascular surface than at the kidney. And by the way, you got to have blood flow to the kidney to deliver BNP to the kidney. And we're talking about somebody who probably isn't making much urine and who has a huge amount of volume in the interstitium, but not really in the vessel. Now, all kinds of heart failure are not the same. So again, I mentioned this earlier, we really talk about two different types of heart failure. We talk about heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. All you see here is the P. P means preserved, R means reduced. Either one of them can present with hypotension or hypertension. Either one of them are life-threatening. And in terms of relationship to mortality and morbidity in the in-hospital statistics, not much different, but we're going to treat them very differently. Because if you have preserved ejection fraction, my focus will not be contractility, it will be ventricular relaxation. So I'm going to use nitrates, I'm going to use beta blocker, I might use calcium channel antagonists. I need your ventricle to relax. I need to know that when my docs are writing the orders for these medications, I need to understand what it is that they're trying to treat. They're trying to treat preserved ejection fraction, that's diastolic dysfunction. If the ejection fraction is reduced, we're going to control ventricular compliance, we're going to control preload and afterload, but now we're going to consider adding in a positive inotrope to support ejection of the ventricle. So pretty much, if you're working with somebody who really knows about heart failure, you can look what the medications are and you know whether they have preserved or reduced ejection fraction heart failure. So lots of classifications of heart failure. I've talked about one part already, and that's systolic versus diastolic. That's preserved or reduced ejection fraction. You can have left side of heart failure, right side of heart failure, or both sides of the heart in failure. You can have mild heart failure that you're completely compensated for. Your lungs really aren't wet. You're not really hypoperfused, but we know that you have a reduced ejection fraction. And as long as you don't stress yourself too much, you're doing okay. Then you move to a more moderate heart failure where you may have wet lungs, but you may not have poor ejection. And then severe heart failure or decompensation. Decompensation heart failure means you have limited ejection, so you have poor blood flow and you have venostasis. That's severe decompensated heart failure. I've got volume, it's in the wrong place. I'm hypoperfused, so I'm cold, and I have venostasis of volume in my pulmonary vault, my central vault, and my peripheral vault. So I'm wet. I'm cold, hypoperfused, and wet, venous and interstitially engorged. So we really think about those relationships. We think about other things that are important in terms of thinking about heart failure. Is it acute? Is it chronic? Is it acute on chronic? Do you have a low output heart failure? Do you have a high output heart failure? High output heart failure is almost always related to thyrotoxicosis or Paget's disease. And what area is the most affected? Meaning backward in the veins or forward in the arteries, right? So it's pretty straightforward. All that terminology is pretty straightforward. We're just going to take a quick look at a couple of visuals. So here in the center, you see a normal heart. Here's a heart with systolic heart failure. You can see the left ventricle is very, very dilated, very large intraventricular chamber, but a reduction in the contractile mass. So this is a reduced heart failure, right? Reduced ejection fraction, or what we call systolic heart failure. Heart failure with reduced ejection fraction, systolic heart failure. Over here, here's your normal again. Over here, you look at the diastolic heart failure, and that typically occurs when you are hypertrophied. And the chamber itself has gotten very small. So see what size the normal heart chamber is, and you can see this chamber is much smaller because you have hypertrophied tissue. You've remodeled your ventricular mass. You've got a big dysfunctional mass of hypertrophied tissue. It's consuming a lot of electrical function and electrical stimulation. I can see that on the EKG, but you have failure to fill. So this patient actually can eject what's in there relatively well, but they don't fill with enough volume. So their ejection fraction is preserved. And so let me explain that. If I fill my ventricle with 200 cc's of volume and I eject 100 cc's, that's a 50% ejection fraction. If I have diastolic heart failure, I filled my ventricle with 100 cc's and I ejected 50. Well, the ejection fraction is still 50%. It's just that I had less volume to eject. So it doesn't mean that you don't have a reduction in your stroke volume, but the problem isn't the contractile tissue. The problem is I have no room to fill the ventricle, okay? Whereas if I go over here to systolic heart failure, I filled the ventricle with 250 cc's of volume, but I only ejected 50. So that means the fraction of stroke volume divided by filling volume has gone down significantly. I've got lots of volume in there, I just can't eject it. That's really the difference between systolic and diastolic heart failure. Now that lends itself very well to the understanding of what we call backward and forward failure. Backward heart failure means that either or both of your ventricles are not ejecting blood normally. The end diastolic volume goes up, and that volume actually transmits backwards, elevating the pressure in the veins. So now I've got a lot of venous volume and a high venous pressure. If I'm looking at CVP, that's high. My neck veins are distended. I'm gaining weight. Every day, I'm gaining pounds and pounds and pounds of weight, which of course we'll never know if you don't weigh your patients and do so rigorously and religiously every day. That's the most important thing you as a bedside nurse can do in evaluating heart failure is daily weight, same time every day, so that you can really get a feel for whether fluid is accumulating or reducing. Typically, patients are not gaining fat weight in the hospital. They're just not eating enough. They're not eating the kinds of food that are going to put on the pounds. Their pounds get put on by fluid. Forward heart failure, same kind of thing. They're both related to actually failure of ejection. But forward heart failure means that you have such a profound, significant reduction in your stroke volume and a reduction in the ejection fraction that you now are significantly at risk. These are seen typically together. I cannot eject forward, and I have filling in a backward state. Forward is in the arteries, filling is in the veins. Okay, so regardless of etiology, the three big things that happen with these patients is they retain sodium and fluid. So they're very fluid overloaded. They have excess fluid in their venous system because they have static fluid. It's not moving effectively into the ventricle and out. So they've got static fluid that's backing up into the lungs. It's backing up into the abdomen, backing up into the extremities. They are very tired. They feel really tired. On exertion, they get very short of breath. So just walking to the mailbox or walking to the bathroom, they get acutely short of breath. And typically they have bilateral, maybe not equal, but they have bilateral peripheral edema. That's really, really important for us to appreciate. The more organs that get congested with venostasis, so not just hypoperfused, but congested with venostasis, the higher your mortality statistics go, which is why we as bedside nurses need to know how to look at these patients. So it is really important in case you are admitting patients who have AICDs or pacemakers. Those patients are going to have more severity when they have heart failure. They already have such significant structural or electrical abnormalities. When they get a burden on the heart, they get an increase in afterload, an increase in preload, or both, they actually are going to deteriorate much more rapidly than other patients. Now, you would have thought that wouldn't be true because you've got an AICD, you've got a pacemaker, but it's not a resynchronization therapy pacemaker. It's just a resolution of the heart rate pacemaker. They are going to be significantly at risk. And I just want everyone to remember, as you look at patients and you're looking at patients' medication history, patients who are in small doses of beta blockers or ACE, they may have a normal baseline blood pressure before those medications got added. Those medications, beta blocker, ACE inhibitor, got added for other purposes, to decrease the sympathetic action at the myocardium, which increases myocardial oxygen. And the ACE inhibitor actually protects your patient somewhat from ventricular remodeling. Remember, remodeling is hypertrophy. Remodeling is dilation. So ACE inhibition and beta block therapy might be used for your patient, not with an interest of reduction of blood pressure, but with an interest of protecting the myocardium. So it's your responsibility to know how much dosing your patient is receiving and appreciating that small doses are usually cardioprotective, whereas larger doses are usually about management of hypertension. So it's our responsibility as bedside providers to be aware of that. Now, I say this all the time whenever I talk about heart failure, weight change has to be known. So maybe at home, you don't have a scale, you don't know what you weighed yesterday, but I know what you weigh today. I need to know what you weigh tomorrow and the day after and the day after and the day after. Daily weights, daily weights, daily weights, daily weights. So here's the thing. I'm just going to mention this. You take it to whatever heart you have. If you've got a good heart, you got a bad heart, you got a right heart, you got a left heart, take it to heart. Here's the thing. You have beds that you can measure weight, and half your beds are broken. Your beds don't work. Somebody didn't zero them. There's an issue, right? You can't weigh your patient. So what you're actually doing is providing really substandard care because somebody didn't send the bed down to be repaired, or they didn't notify you that the bed wasn't working, or they didn't zero the bed before your patient got in it. None of that is acceptable, right? That's just not acceptable. We as bedside providers, we have to stand up for what's right. We're not putting patients on beds that are broken, that we can't weigh them if they have heart failure. We have to be able to do daily weights. Now, it'd be great if your patient can sit on the side of the bed and stand up on a scale. Maybe that's the best way for you to do it. But you're in the ECC with an acute on chronic, or you're very acute heart failure, you're in the ICU and the patient's intubated. We're probably not going to get them up on a scale. But here's the thing, you cannot miss daily weights when we're talking about patients with heart failure. That's something that's we have to commit to. We have to say to our colleagues, you must zero. You didn't zero. I'm gonna have a communication with you. And the first communication is going to be pleasant. And after that, it's going to be an RL, because it's your responsibility to zero the bed before the patient gets in it. If you're putting patients in beds that are broken, my question is why, right? Why? So, I don't have that much power. I mean, if I had power, I would say, well, you got 5 broken beds, those rooms are closed. We're not taking patients. You know how soon that would get fixed? Like fast. But I'm not advising you to do that because you might get in a lot of trouble. And I would probably get in a lot of trouble too. But I think we really have to stand up and say what's right for our patients is we must be able to do daily weights. That's the only way we can truly look at fluid balancing. And when we're talking about heart failure patients, it's all about fluid balance. So when we think about diagnosing these patients, first and foremost, of course, we want to know the patient's history. We want to know, especially if patients are on hemodialysis, they have some renal dysfunction, what's the family history for renal dysfunction? Typically, renal dysfunction is going to be associated with heart failure. Not always, but typically. Going to do a basic physical exam, looking for the presence or absence of fluid in the neck veins and the periphery and the lungs. That's really all we're looking for. We're going to look at your chest x-rays. We're going to look for something very particular on the chest x-ray. We're going to take a look at that. I'm not trying to make anybody into a radiologist, and I'm not a radiologist. I am, however, a very focused on the EKG. And I want to be able to look at EKGs appropriately, make good decisions about what's occurring for my patient so that I can see if they've already remodeled. What does that mean? How am I going to treat them differently because they're already hypertrophied? How am I going to work with this patient to improve basically the quality of life, to try to protect them from generating or evolving into class 4 heart failure, which is cardiogenic shock, which is highly linked to death and also to a very poor quality of life. My purpose is to make sure that doesn't happen if I can. Okay. Patient will need an echocardiogram. I'm not going to perform that, but I'm asking for it. And I'm just tired taking prisoners here. You don't have enough people in the echo lab. Let's get some people. We got a lot of heart failure patients here. We have a tremendous heart failure population. We need to be able to do echoes. We need to have bedside ultrasound. If we can't get an echocardiogram, at least our physicians can do a bedside ultrasound and get a standard level of evaluation. We're going to look at BNP. We don't use ANP here. We only use BNP. And if possible, if we have a central line, all central lines that are placed in critical patients, you should be monitoring them. You should be hooking those to pressure tubing and monitoring them on your bedside monitor. You've got a line, monitor it. You always monitor from the distal port. Try to preserve the distal port. That's the brown lumen for monitoring. If you have a PA catheter, you're going to have more monitoring. That's going to tell you a little bit more about the left ventricle filling, but central venous pressure tells you about right ventricle filling. So that's really good. And occasionally, there will be a consideration. It's a fairly rare situation, but in anybody who we think has fulminating myocarditis. So myocardial inflammation, probably the most relevant time in my career that I've seen more myocarditis than I've seen in the whole 40 years that I've been a nurse was during COVID-19, especially early, because we had really significant fulminant myocarditis. Now, we weren't doing biopsies, we were diagnosing it in other ways, and that may hold true for a long time. A biopsy may be a very rare occasion of the myocardium, and that's perfectly acceptable and wonderful. Okay. So let's just remember about ventricular remodeling and heart failure. We talk about hypertrophy, left heart and right heart hypertrophy. So anything that puts a burden on the left ventricle, so the valves on the left ventricle, the aortic valve and the mitral valve, anything that happens there, anything that changes continuity of the aorta or the systemic arteries, going to put your patient at risk for LVH. Okay. You can also have a lot of abnormalities like an opening between the atria, an opening between the septum. That's an atrial septal defect or a ventricular septal defect. But for most of us, our patients come to us with uncontrolled hypertension, aortic regurgitation, and mitral regurgitation, which is a direct link into class 3 heart failure. So almost non-survivable heart failure in an exacerbated situation. Right heart failure usually occurs because something has caused an increase in the resistance of the pulmonary vasculature. So that would be pulmonary hypertension. It might be a pulmonary embolism. It'll be positive pressure, ventilation, excessive, like PEEPs of 12 or 15, or prolonged inspiratory time. And then, of course, the right heart valves. So the right heart valves are pulmonic and tricuspid. So you don't have to memorize, well, is it regurg or is it stenosis? When you have a right-sided valvular deficit, that can lead to right ventricular hypertrophy. You have left-sided valvular deficit, either aortic or mitral. Those typically, the aortic valve leads to left ventricular hypertrophy, and the mitral valve leads to left atrial hypertrophy. So Just want to remind you what hypertrophy is. Size and weight of the myocardium itself has gotten bigger, usually because there's a very high pressure load. And that pressure load means that not only is it volume, but it's tension that the ventricle is having to generate to move volume. And you may end up with dilation. Okay, so this is just a small picture of hypertrophy. And again, we looked at it before. You can see here's your right ventricle diameter and nice thin right ventricular wall. Left ventricular diameter a little bigger than the right there, and a much thicker wall. And then with hypertrophy, the wall is even thicker and the chamber has gotten really, really small. So again, you have a preserved ejection fraction because you've got a big muscle, but you don't have any room to fill it. That's the preserved ejection fraction heart failure. That's diastolic dysfunction heart failure. And that's a really common first step. Hypertrophy is the first step. Now, when we look at the EKG, I really like to remind you, because you're the ones looking at the EKG, got ordered, it gets done. You should always ask for a paper copy, always. And you want to look at that paper copy. So what I've done here is I put 2 lines. I'm not looking at anything over here right now. When this is not a 12-lead EKG class. I just want to talk about looking at the right heart and the left heart using the chest leads. So I drew a line here at your right-sided chest leads, V1, V2, V3, and that's what I'm using to reflect the right heart. And this red line here for V4, V5, V6 that I'm going to use to look at the left heart. And here are the simple questions. So I didn't write them down. I put this program together at like 2 o'clock or so. I mean, I had some slides from other things, but a lot of them were just new creations. So I'm sorry I didn't write this down. But when you look at the chest leads on your EKG, you're going to ask 3 questions. Is the current direction normal? Okay, so first and foremost, current direction is always to the left heart. That means that when I look at these 6 leads, what I expect to see is that the current is going away from the right side, which means that is a downward deflection, away from the right side and towards the left side. So downwards in the right-sided cardiac leads and upwards in the primary left heart leads. And that can be V4, V5, V6, but at least one of them, you've got to see a really big upright. So big downwards on the right side, big uprights on the left side. Now that can be normal. Okay, so that's the first thing. Is direction towards the left, yes or no? And in this case, yes, direction is away from the right. Here are my right-sided leads, and towards the left. Here are my left-sided leads. And then I'm going to say, was the voltage bigger than normal? Voltage should never be more than a millimeter, which is a millivolt, which is 10 small boxes on a standard EKG. Okay, well, you can see here, it's over 10. Here, that downward picture is greater than 20. And down here, it's also greater than 20. It's almost 30. And then when I go over here on the left-sided lead, I'll see that in this upright, it's around 15. And in this upright, it's around 20. I'm going to add those 2 together. So let's just say this is 30. This is 20. I'm going to add those 2 together. And that total is 50. So the downward, really big, and the upright, really big, added together. Added together. So what we call it is the S wave on the right-sided leads and the R wave on the left-sided leads. Add them together. If together they're greater than 30, you have ventricular hypertrophy. Okay, so number 1, direction. Number 2, voltage. How deep, how tall? How deep on the right, how tall on the left? And then the third question, it's the last one. How long did it take? What's the time? If the time is less than 0.12, then you don't have a conduction deficit. So it's pretty straightforward. What's the direction? What's the voltage? And what's the time? So here I have normal direction to the left, but extraordinarily big voltage on the downward side, meaning voltage away from the right heart, down, 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 down. And over here on the left side, up, 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 up. And total is greater than 50. So that's a really big voltage. Okay, so directionally it went to the left, which was what I want, but it was a lot of voltage. And now I'm going to look at time, and the time is about 0.08 seconds. So time is normal. Time is less than 0.12. So direction is normal, lots of voltage, and a normal time. That's ventricular hypertrophy. It's pretty straightforward. And all I'm going to do is just divide my chest leads into right heart and left heart. So you can see here, I've got this big R wave here, and over here in V3, a really deep S wave. I've added those two together. That's greater than 50. That's left ventricular hypertrophy. It's pretty simple. Now I'm going to look at right heart, and it's going to be exactly opposite, right? Because if I have right ventricular hypertrophy, all the current now is going to be shifted to the right heart, which is completely abnormal. It should never be shifted to the right heart. It should always be going to the left heart. I know it's shifted to the right heart because I have an upright here in the right-sided lead. Right-sided lead should always be downward, but these are upright. So current is going to the right heart. Now I'm going to choose the right-sided lead. That's the biggest upright. That's this one. It's around 15. And I'm going to add that to the downward perspective of the left heart, and that's going to be around 8. This only has to be the right heart plus left heart, and right ventricular hypertrophy only has to be greater than 20, and we're at 23. So current is going towards the right, wrong direction, a lot of voltage greater than 20, and again, very important, the time it took, and the time is 0.08 seconds, so it's 2 small boxes. So normal time, wrong direction, lots of voltage. Wrong direction, lots of voltage, normal time, right ventricular hypertrophy. Now, why do you even care? You're just like, well, I don't care about that. My doctors look at the EKG. Yeah, your docs look at the EKG. Most of them are not looking at hypertrophy unless they're cardiologists. And it really is important because that's going to correlate to your symptoms that you're seeing and that you're treating. When you have ventricular hypertrophy, remember you have diastolic dysfunction. Your lungs are going to be wet, your system's going to be wet. And because you have a reduction in the volume that fills the ventricle, even though you can eject it, you don't have enough volume in the ventricle to maintain a normal blood flow dynamic. Your patient is really critical, and they could become severely critical. And by the way, they're probably going to become hypotensive, and your number one goal will be to get their blood pressure up. You'll add a vasopressor, that will make them worse. That's why you've got to understand this at the bedside when you're evaluating your patients. Now you move from hypertrophy typically to dilation. Okay, so you can see now what's happened to that ventricular wall is used to be hypertrophy, but now it's really thin. And the ventricle is very dilated. So now I have reduced ejection fraction because I had a hypertrophic muscle, but now that muscle wall is really thin. And some patients don't go through hypertrophy, they just go straight to dilation. But most hypertrophy patients end up with dilation. And as they become dilated, they lose the ability to contract and eject. Now they're going to reduce their ejection fraction. Now they have heart failure, REF, reduced ejection fraction. And your goal is you want to reduce the volume that's in the ventricle, but you need the ventricle to empty better. So that's going to be the time that you're going to think about what kinds of therapies you're going to provide to the patient to improve their cardiac ejection, mobilize their volumes forward. Now, we're not going to make diagnosis of this from an EKG, and we don't really do that with hypertrophy either. We really need an echo, but you can have some signals on EKG that tell you about hypertrophy. But here you see, this is a huge left ventricle, really dilated left ventricle, really big left atria, a small right atria, a small right ventricle. This is typical view of LV dilation. And here, a typical view, you can see the RA is much bigger than the LA. That shouldn't be. They should be relatively equal. So that's really a telltale sign. Got this huge right atria, a huge right ventricle, and the wall that separates the two is pushed over to the left heart. So I've got this great big right ventricle with right ventricular dilation. And now this problem with the right ventricle, which is reduced ejection fraction and a lot of filling and dilation, shifting that wall over the LV has now made the LV with a preserved ejection fraction, but a reduction in the volume loading because the chamber is so much smaller. This is really worrisome. So here's the endpoint of ventricular remodeling. Okay, let me make sure you appreciate this. Every patient that you have that has had a STEMI should not leave the hospital without ACE inhibitors or angiotensin receptor blockers. So they leave your CVICU and they're not on that. You need to encourage the next nurse to make sure that that gets ordered on that patient, okay? Because this is ventricular remodeling. And once the ventricle is remodeled, you can't get it back. So you'd like to protect your patient. Remember, you might see patients that are on low dose ACE inhibition or ARBs. That is cardioprotective, to protect them from ventricular remodeling. And it's the only drug that we give that protects you from ventricular remodeling. Okay. Now, again, I'm not trying to make anybody into a radiologist. I just want you to take a quick look kind of at radiographic features for LV failure. And there really are three basic stages. We're only going to really look at the first one and the second one. Third one you see all the time. It's the whited out lung. It's not that hard to diagnose that because you can see that you've lost a lot of air pockets. Okay, this one, the first one on a chest x-ray, what we actually will see is that you see some enlargement of the vascular surface that is on the cephalad point. So at the higher levels, so really more towards the apices, you're seeing here, what you're seeing is sort of engorged vessels. And that's typically because you can't fill the left atria, so the vessels get engorged with volume. That's an early sign. It's a mild pulmonary congestion sign. You might look at that x-ray if you didn't know much about x-rays, and you would say, oh, that x-ray looks pretty okay. But you can see that the vascular surface here is much more highlighted than normal. You shouldn't normally see the vascular surface like this. So this is what we see with mild pulmonary congestion. And then we see a more significant pulmonary congestion. So I like to talk about this because I'm a nurse practitioner, I'm a CNS, but I really never understood curly B lines. And you'll hear your docs will say, oh, they've got curly B lines. So what curly B lines are just again, kind of a relationship of venous engorgement and fluid extravasation out into the interstitium. So this is actually interstitial volume out of the vessel, interstitial volume kind of in a controlled chasm that's within the pulmonary bed. So you're seeing it's not curly. Curly is the name of the doctor, so it's not in curls. And it really is just kind of these little short centimeter lines that are almost perpendicular to the end of the pleura right here. That's the pleura. So you're seeing these little lines here. That's an advanced congestion. That's before you see whiteout, you're going to see this. So if we're looking at the chest x-ray and if we feel comfortable and we say to our doc, are these curly B lines? Yes, they are. Thank you so much for telling me, because that's going to change how I'm going to treat the patient. It's going to change my decision about diuretics. It's going to change my decision about nitroglycerin. It's going to change how I'm going to manage this patient when I've seen that they have this interstitial fluid leak known as the curly B line. Now, clinical signs, and there's a lot of them. There's some really big important ones, and they're pretty straightforward, these big important ones. Your patient can't lay down, he has to sit up. Sometimes he's tripoded, but he just has to sit up. He can't lay back, he huffs and puffs, he can't breathe. That's the most important sign of all. You got somebody who can't lay down, can't lay back, can't lay at 35 degrees, it's got to be up to 45 degrees or even more. They're leaning forward on their elbows or their arms. That's the only way they can breathe. That's the most important sign. More important than the echo, more important than the EKG, more important than the chest x-ray is your patient position, the most important sign. They could be hypertensive, they could be hypotensive. So that doesn't really help us very much. But if they have distended neck veins, that's a surrogate for the right heart. If they have wet lungs, that's a surrogate for the left heart. So remember, I'm looking at your position. I'm looking at how you best are resting. And if you're sitting up and sitting forward, you are having trouble breathing. I'm all over that like a fly on a Cheeto. I'm not letting somebody just blow me off and say, yeah, I'll get there when I'm doing rounds. No, no, no. This patient is struggling to breathe. He's sitting in a tripod position. And when I listen to him, I hear wheezes. When I look at his pulse ox has dropped. I need you to come now. You need to look at the patient now. Now, if you're good with heart sounds, and it's really hard to listen to heart sounds in a busy unit, in the busy ER and a busy ICU, you really need a quiet space to listen to heart sounds. But typically patients with heart failure, they oftentimes, depending on the kind of heart failure they have, will present with an S3. That means you have an extra sound during the diastolic time. So S1 is the beginning of systole, S2 is the end of systole. And then all the way to the next S1 is diastole. Earlier in diastole, if they have an extra sound, that's going to be an S3. Really late in diastole, if they have an extra sound, that's going to be an S4. S3 is really diagnostic for acute heart failure. So that's always really important to think about. And if you know the patient, you've been listening to them for a couple of days with your stethoscope, and 2 days ago, their heart sounds were pretty good, and now they're distant, that's also going to be really meaningful. But really, quite honestly, I think it's very hard, unless you're very skilled, to really identify abnormal heart sounds, even though you all chart them and you throw in some abnormals every once in a while. I think pretty much people just say, oh, I heard S1, S2, and I think I heard S3 because I heard something abnormal. And I don't really know what it is, but I'm going to say it's an S3. Well, an S3 correlates to acute heart failure. And then, of course, typically bilateral leg swelling may not be equal, but both legs are relatively engorged with volume. Now, there's lots of other things that you will see with these patients, but I want to focus now on extravasation of volume in the abdominal vault. So if I have left heart failure, primary, secondary right heart failure, I now have volume in my systemic veins. I have fluid creep into the abdominal vault, which is a big space. And that means now I have ascites, and I am actually compressing the liver. There is a sign that is really, really important. And that is that I have my patient at less than 30 degrees elevation. I press down on the liver for 20 seconds. I should see the neck veins distend. If that happens, they have severe right heart failure. That's called the positive hepatojugular reflex. Now, all these other signs are really important. Patient can't breathe, he needs pillows, he has acute pulmonary edema. On exertion, he's very short of breath. These are all really, really important signs. The most important one are some of the easiest ones: the patient's position, the distension of the neck veins, and their breath sounds. And that's something everybody can do. You don't have to be a specialist to look at that information and to be able to plug that together with the other things you're looking at that are telling you about a patient who's in heart failure. What happens next if we don't manage this is obviously all that high hydrostatic pressure, pushing that volume out, pushes volume out into the pleural space. Now the patient's got a pleural effusion, pushes volume out into the abdominal space. That causes venous congestion in the abdominal vault. It actually causes very significant liver compression and renal compression. So in addition to maybe having poor blood flow forward, I also now am compressing those organs. Because I'm not emptying my ventricle appropriately, I am going to be at risk for the development of a clot in the ventricle. That's a ventricular thrombus. That's pretty common that we see when we have patients who have dilated, that's why you need to know that, dilated ventricular chambers, because they have a lot of blood stasis in there and they form clots pretty aggressively. And of course, patients can have dysrhythmias, and they can be quite significant. Those dysrhythmias that are caused by their heart failure and causative of their heart failure. Okay, so I have very particular goals. I'm not talking about every medication known to man here. That'd just not be worthwhile. But what I want to understand and appreciate at the bedside, it's not really my Mosby's care plan. In my mind, with a person with heart failure, I need to optimize their forward volume. So normally how I do that is I reduce their venous return. So I optimize their preload. I reduce their venous return. I decrease their overall intravascular volume. Now I'm going to start that with administration of diuretics. And I'm going to start with loops. And then I might look at loops and potassium sparing. And then I might consider myself, I might consider slow continuous ultrafiltration using my CRT device. You might be in a place where you have a lot of support for what's known as aquapheresis, which is fluid removal. I'm not that much in support of aquapheresis because I want a nephrologist in charge of fluid removal. And I want it to be through a central catheter rather than a PIC or a midline. I'm not sure which one that you use here when you do aquapheresis. I'm just letting you know, I would prefer scuff, which I think is much more controlled, but we rarely do scuff here using our Prismax devices, although we could. So I'm going to give you diuretics, and then I'm going to think about removing fluid. I want to improve your breathing. Remember, the first thing I'm going to do is put you on CPAP, and if necessary, I'm going to put you on BiPAP. And that should happen in the ED, that should happen on the med-surg floor, on the tele floor, and in the ICU. I want to avoid intubation at all costs because it's going to put a very significant burden on the ventricle. So I'm going to try to avoid intubation and manage you first, if your problem is oxygen, with CPAP. If your problem is oxygen and CO2, I'm going to do that with BiPAP. I'm going to try to avoid intubation. Now, all of that is going to reduce your cardiac work. As I reduce your cardiac work, you're going to improve your cardiac function. As you improve your cardiac function, you're going to have better blood flow delivery and better gas exchange, oxygenation, better metabolic delivery. Everything is going to look a little bit better. So what I'm going to think about categorically, when my physician orders 12 drugs, I need to appreciate what category they're in. Am I decreasing the afterload? Am I optimizing the preload? Am I increasing the contractility? These are the three things that we do with patients who have heart failure, whether they're cardiac patients or septic shock patients with heart failure. These are the three things that I'm going to do. I want to optimize your preload and assure that you are not volume overloaded. I want to decrease the tension required by the ventricle to overcome resistance. And I want to improve the inotropic function of the heart. So remember the picture we had before. Sorry about that. This was the picture we talked about before, right? This is the load you're moving. That's your preload. This is the tension you're overcoming to move your preload. That's the afterload. Here is your inotropic support, pushing that preload against the afterload, and that's performed by cardiac work. So now, whoops. Okay. So now let's look at somebody in heart failure. So that preload burden has gotten much bigger, right? It's gotten much bigger than the normal heart. We've got a big preload burden. Preload is increased. You got venostasis, you've got high venous column of blood, you have high venous pressure, you have interstitial fluid creeping, patient's gaining weight every single day. He has peripheral edema, bilateral on hands and feet, and he has abdominal edema. He's in trouble. He's got a really high preload. His afterload, you can see, has increased significantly, okay? Because part of the compensatory mechanism is to vasoconstrict and venoconstrict, delivering more volume back to the heart and putting more resistance against the heart. So he has very significant afterload increase. The tension of the ventricle must be much higher to overcome this resistance and deliver the preload against the afterload. So I'm looking at your preload is up and your afterload is up, but because you've lost so much of your myocardial function, your inotropic function is down. So I had to do it the best way I could. I just blocked out all the other people. So you really only have a half a man back here pushing that stagecoach because I've lost my inotropic support. And that means the cardiac work has gone up significantly and extraordinarily. So now as the cardiac work goes up, oxygen demand has gone up. And what I need to do is reduce your preload, reduce your afterload, and increase your inotrope. That's what I'm going to do. That's what the plan is. That's what we're going to do at the bedside. So remember, we do preload reduction by diuretics, by fluid restriction. We use venodilators. That's going to be nitroglycerin at doses of less than 50. It's primarily a venodilator. That's the best venodilator we have. So low dose nitroglycerin will dilate the veins and reduce the volume burden back to the heart. Lasix is a venodilator. Morphine sulfate is a venodilator. Typically, we don't use Lasix for venodilation or morphine for venodilation, but we can use low-dose nitroglycerin. And typically, I'm going to want to do that continuously because I want to see the effect and I don't want to unload you too much. I'm going to use aldosterone agonists. So aldosterone agonists will be like spironolactone. That's a potassium-sparing diuretic. I want you to be on a beta blocker. You're really going to be on all of this to reduce your preload. But I'm going to expect a bedside nurse to assure that that patient stays in sinus rhythm, because in sinus rhythm, you have normal atrial contraction and filling of the ventricles. So that maintains ventricular filling. As soon as you're in AFib, you've lost that atrial systolic contraction. You cannot allow patients to stay in AFib. There are many burdens and risks associated with it. When we're talking about heart failure, AFib exacerbates heart failure so significantly. We've really got to try to get them out of AFib. Now, the other thing that you can do, but it's very unusual, is to pace both the atria and the ventricle. That's known as AV pacing. Transvenous pacemakers, generally, you're not going to be able to do that. Your patient has to have a permanent pacemaker implanted, or they have a pacemaker that they come out of the OR with. So that's kind of a hard stop. If you're talking about a patient who's on a step-down floor, you're using transvenous pacing, but already that's actually propagating some heart failure when you use transvenous pacing. Okay. Afterload reduction. When I want to reduce the resistance to left ventricular ejection, I'm going to use vasodilators primarily, arterial dilators, nitroglycerin above 50, cardine, agents that are going to promote arterial dilation, reducing ventricular tension. And as I reduce ventricular tension, I reduce ventricular oxygen consumption. I'm going to use vasodilators. I'm going to use ACE inhibitors. Those are also going to be vasodilators, and they're also going to reduce my preload and at the same time reduce ventricular remodeling. Wonder drug ACE inhibitor, really a great agent. And again, beta blockers that have some effect on the arterial bed. So I'm going to look at beta block that has more beta 1 plus beta 2 rather than beta 1 alone. And that's how my pharmacists and my physicians hopefully are going to order that. If it's a right ventricular afterload reduction I'm going after, first thing is I am not going to allow you to be hypoxic. So remember, I'm going to put you on CPAP right away. I'm going to advocate for you to go on BiPAP if you need it. But first and foremost, if your problem is oxygenation, but not carbon dioxide, so you have a normal CO2 level, but you're low oxygen, I want you on CPAP. And yes, it might be an extra work for me to get that CPAP going. The respiratory therapist can't do it. We got to get it going. They bring it in, they kind of set up, they say, you make sure the patient's okay, you got to do it. Same thing with BiPAP. They bring it in, they set it up, they fit the mask, they say, I got to go. You make sure the patient's okay. You got to do it. You got to be normoxic. And if you are retaining CO2, you need to be normal capnic. That's going to unload your right ventricle. I'm not allowing patients to desaturate and be hypoxic and hypercarbic under my care for 4 hours, 6 hours, 8 hours, 12 hours. I'm too busy. I got too many patients. I'm sorry. No, your patient needs to be normoxic and normal capnic, or else you're going to put them in right heart failure. Then the other point there is that if they are intubated, you have to be very, very cautious about excessive positive respiratory pressure. That positive respiratory pressure in intubated patients will be related to PEEP and the time of inspiration, known as pressure control inverse. If I have to use PEEP, and I might, then I need to put you on a pulmonary vasodilator so that I can balance the vascular resistance to the increased resistance that I've given you with your PEEP. So afterload reduction, really important. You're not writing the orders, but you are enacting them, and you're the one who's advocating for the patient. So you got to share with your doc, I see signs of left heart failure, I see signs of right heart failure, I see signs of biventricular failure, and my patient is deteriorating, and here's how it's happening, and here's what I would like. What do you think? Okay, and then of course, improving cardiac contractility. Now in general, we are not going to work at improving cardiac contractility if our patient doesn't have a reduced ejection fraction. Remember, if they've got preserved ejection fraction, what I need to do is make the ventricle more compliant. I need to reduce the resistance of the ventricle. So I'm going to do that with reduction of preload and reduction of afterload, and that should be good enough, right? So I'm going to give you diuretics. I'm going to give you ACE inhibitor. You might go on some low dose nitro. You might go on a little bit higher dose nitro, depending on how acute you are and what's occurring for you under my care. But if you have a reduced ejection fraction, and that is putting you at risk, before your patient is in class 4 heart failure, before they're in cardiogenic shock, you want to recognize that they have a poor ejection fraction. Now, does that require that you have an echo to make a full diagnosis? Yes. But if their systolic pressure is really low, if you can't get a pulsatile waveform for their pulse ox signal, that pleth, which is the pulsatile waveform, you have to consider that they don't have good systolic ejection. Systolic pressure is low. They don't have a good pulsatile signal. You have to consider that they have a reduced ejection fraction. And when you have a reduced ejection fraction, we're going to manipulate your preload, we're going to manipulate your afterload, but you're probably going to need an inotrope. Now, the only inotrope that we have that is an oral inotrope right now is digitalis. It's a really weak inotrope. Nobody likes to use it. We don't want to. But what we do have are really 2 really great IV inotropes, dobutamine and milrinone. So I've talked a lot about dobutamine. I've talked a lot about milrinone in other situations. I'm not really going to cover those agents, except to say, in a chronic heart failure patient, you would start at a standard level of dobutamine. That would be 5 mics. If your patient this is their first episode of heart failure, never start at 5 mics. That's going to be too much for the patient. So you got to start lower. The reason you use a higher dose in a chronic heart failure patient is that they have desensitized beta receptors. You have to use a higher dose of drug. There's also a form of pacemaker therapy we do it here, but we don't do it often. It's called cardiac resynchronization therapy, and it actually synchronizes the atria and the ventricles. So you've got 3 lead wires, one that goes through the coronary sinus into the LV, on into the RV, and the other into the RA. And you may actually also have a fourth lead into the LA so that you are actually synchronizing ventricular activation and ventricular contraction, which will significantly improve your patient's ejection fraction. The other thing, and you don't do that, you just need to know that we can do it. We don't do it that often. I think we're going to be doing it more now that we have a second electrophysiologist. The other thing you want to think about are the supporting hormones for myocardial function: insulin, thiamine, thyroid, cortisol. Every patient who has heart failure needs a hormone panel. So you may not be able to interpret that. You're not the one writing for the drugs, but you're the one asking, can we do a hormone panel on the patient so that we can assure that we're doing the best we can to maximize their ventricular function? That's what I need to do as the bedside nurse. And then I just want to remind you that there are a number of emergent things that occur while patients are under your care that will put them precipitously in profound heart failure. They have ACS, they have a STEMI or a non-STEMI. Be aware that can topple your patient into severe acute heart failure. They have an uncontrolled hypertensive emergency where we're not controlling them immediately. We've allowed them to kind of go up and up and up on their blood pressure, and they've had a high blood pressure now for 4 or 5 hours. That can put patients really aggressively and rapidly into heart failure. Don't allow that to happen. If they have significant dysrhythmias, and that would be AFib, a flutter, ventricular dysrhythmias, or frequent early depolarizations, we should always have a discussion about it. I want to remind you that if you have acutely gone into atrial fibrillation, that is not your chronic rhythm. This is not a chronic rhythm. And you have exacerbated heart failure, you need to be cardioverted. We don't like to cardiovert somebody with chronic AFib because they may have a venous thrombus. We need to anticoagulate them before we ever do any cardioversion. But if you've got acute AFib patients who are deteriorating under your care, you need to cardiovert. And that's wherever you are. You're in the surgical ICU, the ECC, wherever you are. If you know the patient's history, you know they didn't have AFib, they don't have the possibility of a venous thrombus, you cardiovert when they go into AFib because they can reduce their ventricular filling by 60% when they're in AFib. So it doesn't matter if they have a good contractile state. Now they haven't got filling volume and they're in heart failure. Okay. It is absolutely necessary to think about echocardiogram as a confirmatory diagnostic tool. We don't do the echo, but we're asking for it. Oh my goodness, it's 5:30. And then acute pulmonary embolism. So I just want to remind you, patients under your care are at risk. This is a patient who is in stage 3 heart failure, who actually then had a STEMI. He had an infralateral STEMI, and you can see he's really acutely at risk. He's losing muscle mass by the second. He's got to get to the cath lab. We've got to open that vessel. Okay, so what you need to do as bedside nurses, you need to anticipate in every patient, whether they have cardiac history or not, that you're going to test whether or not they can respond to diuretics. You're going to give a testing dose, 20, 40, 60, 80. You're going to escalate their diuretics, trying to actually improve their urine output and the clearance of volume. You got to do weights every day, same time. You're going to think about arterial dilation. And remember, there's a fine line between decreasing afterload and promoting hypotension. You're going to consider positive pressure support with CPAP or BiPAP. Very useful. The number 1 category of patients who respond are COPD, and the number 2 are heart failure patients, CPAP and BiPAP. Try to avoid intubation if you can. Introduce CPAP and BiPAP early, stay with the patient, work with them, get them to be comfortable because it's going to feel like they're suffocating. But if they can adapt to CPAP or BiPAP, they're going to do so much better. If we don't need to intubate them, they're going to do so much better. So anticipate that. Anticipate that you may need to do a pleural centesis. That may be absolutely necessary to remove fluid so that they can expand their lung. It also may be necessary to do a paracentesis in ascites because they've got so much fluid in the abdominal vault, and that is compressing the liver and compressing the kidney. That actually communicates to what we call increased intra-abdominal pressure. That compresses the renal artery, the renal vein, the IVC, and it causes significant deterioration of the patient. So when I'm seeing that a patient under my care, their liver enzymes are increasing, their glomerular filtration rate that's coming back to me on the chemistry is going down, and they have not been making urine, I am going to get a scanner myself. I'm going to do a bladder scan. I'm going to ask my doc to look at the abdomen, and I'm going to be prepared that we might need to do a paracentesis to help mobilize the volume. Also be aware that we don't want to allow them to have anemia. Packed cells are going to increase their oxygen carrying capacity. Might need to give them calcium. Absolutely have to actually evaluate their thyroid function. Everybody with heart failure needs a thyroid profile. And be aware that they may also have significant reductions in their calcium, and calcium is a myocardial contractile agent. That, my friends, is that. So I'm going to stop sharing. Happy to answer any questions. I was just so excited about talking about this. I did not